Thank you very much, Mr. Chairman. I'd like to thank the organizing committee. It's a pleasure to be here in a tough position to discuss with my friend Safi. And we're going to talk pro-resection in patients with hepatocellular adenomas larger than 5 centimeters. I respect my opponent. He's my friend. I like France and French people. And he's a big authority. He's one of the surgeons who mostly publish on this subject. And of course, France is the world champion, and we have to respect them. Hepatocellular adenoma is a benign rare tumor affecting young women, and this is the biggest problem. Our population are almost always young women, with history of prolonged use of oral contraceptives. Other etiologies include use of steroids, glycogen storage diseases, iron overload, and nowadays metabolic syndrome pointed to be a very, very important cause of hepatocellular adenomas. So the population we are going to discuss are young women in childbearing age taking contraceptives, eventually with a metabolic syndrome. Usually it is an incidental finding on images or eventually for unrelated reasons. It's a very, very heterogeneous disease compromising distinct molecular aspects and complication profiles. In the last decades, 4 subtypes of hepatocellular adenomas have been identified based on a genotype-phenotype analysis, and I'm going to talk a little bit later about the new classification, very complex. What's the problem regarding hepatocellular adenoma? It's the risk of hemorrhage that can occur in up to 30% of the patients, and malignant transformation that has been described between 4 and 80% of the cases. So we have a lesion that has a risk of bleeding and a risk of malignant degeneration. So should we resect all hepatocellular adenomas? And the answer is no. Of course, this is score for France. Safi scores for France. When I say no for all adenomas. However, in the next minutes, I will show you that the huge majority of adenomas larger than 5 centimeters have to be operated. The classification by the pathologists from Bordeaux, France, they did a fantastic work trying to classify the hepatocellular adenoma at the beginning of the 2010, 2011, 2012, and this is the classification most of you are used to apply in your day-by-day practice. Females using oral contraceptives, there is a mutation on HNF1 alpha inactivation in about 30–40% of adenomas that leads to a steatotic adenoma, which has a very, very low risk of malignization and of bleeding. These 2 groups of liver cell adenomas are the groups at risk. The inflammatory adenoma that is related with obesity and alcohol intake, and they are called inflammatory adenomas. They have an inflammatory infiltrate, dystrophic vessels, telangiectasic vessels, and what's the problem regarding the inflammatory adenoma? Is the high risk of hemorrhage. And the other group, about 10 to 15% of the patients have a beta-catenin mutation with activation of beta-catenin, which is more common in the male gender and is associated with the high risk of malignant transformation. About half of the patients, males who have beta-catenin mutation, they have risk of malignant transformation. And there is a group, about 10% of the patients, with an uncertain, unclassified behavior. So, when we talk about risks, which are the risks for malignant transformation? Male gender, as I told you, use of anabolic agents, androgen agents, large tumors, larger than 5 centimeters, and beta-catenin mutated hepatocellular adenomas. So, larger than 5, risk for malignant transformation. And what about for hemorrhage? Large tumors as well, larger than 5 centimeters, and inflammatory hepatocellular adenomas. So the adenoma that is larger than 5 centimeters is at risk for hemorrhage and malignization. I think I'm scoring here. Sophie? Let's look at the literature. There's a systematic review regarding hemorrhage and rupture of hepatocellular adenomas. This is a very nice paper from the group from Netherlands. They showed about 27% of risk of hemorrhage, but very interestingly, they say that the risk of an adenoma smaller than 5 centimeters to bleed is really, really small. So those at risk are larger than 5 centimeters. This is a nice paper, and my opponent is one of the authors from the Boujon, showing that they had 10% of malignant transformation. We are watching here the malignant transformation. The majority men, what means that half of the men with adenomas, they have malignant transformation, and just about 4% of women. And they have shown that in women who are taking oral contraceptives, malignant changes were not observed within small adenomas. So the risk is for patients with adenomas larger than 5 centimeters. They have also shown that the steatotic patients, they have no malignant transformation, and this is a very important point. However, all other types, inflammatory and classified, those are typical, all had cases with malignant transformation. So all other adenomas that non-steatotic are at risk for malignant transformation. When we look at the guidelines of the European Association of the Study of the Liver, it's a very interesting point that nowadays, using MRI, we are able to identify about 90%, we are able to classify adenomas in about 90% of the cases when they are steatotic or inflammatory. It's very difficult to characterize beta-catenin mutated adenomas reading the MRI, but it's very sensitive, especially for those cases with steatosis. And if you look at the guidelines, for nodules equal or greater than 5 centimeters, we should resect. I think it's called again. This is a very nice guideline algorithm proposed by Safi's mentor, professor, and my friend, Professor Jacques Belghiti, showing that in adenomas larger than 5 centimeters, when you have the telangiectasic, what means inflammatory types, and beta-catenin, you should go to radical management. And those steatotic adenomas, those with HNF1 alpha mutation that leads to steatotic adenoma, he proposed biopsy to confirm it is a steatotic adenoma, and then surveillance. So the only group that it is not necessary to operate, as I said at the beginning of the lecture, was the steatotic adenomas. Here we are going to discuss a little bit about the biopsy. We don't think the biopsy is necessary in this kind of group. It has been shown, as I showed you in the ESO guidelines, and in many, many papers regarding MRI evaluation of adenomas, that the steatotic adenoma is very, very easily identified by MRI. So there's a typical presentation in the steatotic adenoma. In inflammatory, not so good, but about 75%, and in beta-catenin is a little bit difficult to characterize at MRI. This is a very new paper. The group of the French pathologists, especially the group from Bordeaux, pathologists Paulette Dulac-Sage and Jessica Zuckman-Rossi, they have been making a fantastic effort to try to understand everything about adenomas. And they collected more than 600 samples from 28 centers in France. And they looked for gene expression, RNA sequence, exome genome sequences, immunohistochemical analysis, and they found 8 subtypes of adenoma. Not more 4, but 8 different subtypes. The steatotic, the adenoma with beta-catenin mutation in exon 7 and 8, the inflammatory adenoma with beta-catenin mutation in exon 7 and 8, the inflammatory typical, the inflammatory with beta-catenin mutation in exon 3, the sonic hedgehog adenomas, as I'm going to tell you a little bit later, and unclassified. So it's a very, very complex classification. And if you see the beta-catenin mutation, intracellular, intranuclear, with an exon 3 mutation, is that one who leads to malignant transformation. And the sonic hedgehog, subdifferentiation of the inflammatory adenomas that was observed in about 4% of adenomas, is associated with bleeding. However, we have to point out that this is too complex. This is research, this is really, really necessary, but it's almost impossible to apply this in the day-by-day practice. So we have to discuss if all those alterations, all those pathological findings are possible in a simple biopsy. Of course not. They looked for specimens. And looking for specimens, you can do a very, very nice molecular profile. I have been talking to you about the doubt about biopsy as a routine. All hepatocellular adenomas, tumors like this, hypervascular tumors. And one author has studied the risk of a malignant biopsy of an adenoma. Of course, we have low complications, 10% of minor, however, 2% of bleeding, significant bleeding. And what calls the attention is that they found 10% of discordant diagnosis. What means we're talking about specialized centers. In the day-by-day practice, many times you can have diagnostic, an incorrect diagnosis. So there's a small risk, but it's not negligible. When we discuss about the immunochemistry and the pathologic evaluation of adenomas, authors really say it's really difficult because they look at glutamine synthetase at the nucleus, and based off a high concentration of this immunochemistry marker, they look for beta-catenin mutation. However, it is really, really very heterogeneous. And when the French authors, these pathologists, discuss about this, they say that they recommend to assess glutamine synthetase expression far from necrotic areas, far from peleotic areas, far from hemorrhagic areas, far from cholestatic zones. What does it mean? That they have all the specimen to look the best place to study, not a simple fine needle biopsy. And this is a very, very important message. So we have studies with small number of cases, because it's a rare disease, a very heterogeneous disease, and the steatotic adenoma that can be easily identified on MRI is at low risk for complications, so you can apply a non-operative approach. What has to be discussed in adenomas? When to perform a biopsy? This is an unanswered question, because as I told you, a fine needle biopsy many times can't tell you everything about that adenoma. The usefulness of immunochemistry evaluation, of course, in specialized centers, it's very good, but in daily practice, in the majority of the groups, is not so easy. And of course, the full molecular profile, as I told you, with 8 different subtypes. This is research. This is the future, of course. We are going to work with that. However, this is not available in the real world. Lastly, we're going to talk a couple of minutes about laparoscopic resection. We think that hepatocellular adenomas are the best indication for a laparoscopic liver resection. We are talking about a benign tumor in a young woman, where cosmesis and fast recovery are really, really important. So we have published a paper a couple of years ago, and now we have 61 cases of laparoscopically resected adenomas with very, very low morbidity because they are young patients with no mortality. So it is very good to apply this kind of treatment, minimally invasive, for those patients. There has been a multicentric French study, in which my opponent was one of the authors. I told you he's an expert on the field. And laparoscopy can achieve excellent short-term outcomes with reduced bleeding, reduced need of transfusion, and shorter hospital stay. So those are a very, very good group of patients to treat with laparoscopy. Concluding, Mr. Chairman, ladies and gentlemen, In the front of the goal, the forwarder must score. Otherwise, despite champion, he is not a good forwarder, as France's forwarder. In front of a patient who is at risk, surgeon must resect. Non-steatotic adenomas larger than 5 centimeters should be resected by laparoscopy if possible. Otherwise, you are not doing the best for your patient. So, non-steatotic adenomas should be resected. Of course, Brazil wins. Brazil 5 times world champion, wins the debate, and France 2 times world champion. And the current world champion, so we have to respect, loses. Thank you very much.